So we're here today again with Dr. Hal Dietz, who's going to be answering some questions about medications that have been submitted when he presented his webinar a few weeks ago on a research update. So let's get started right away. Lots of questions about losartan. What dosage of losartan is currently regarded as the optimal dosage for preventing aneurysms?
So that's a great question. It's a question that we've been trying to address. We have done considerable work with animal models of Marfan syndrome, and we found in those animal models that the further we pushed the dose of drugs like losartan or irbesartan, the better the performance of the aorta. That was true even if we pushed the dose of the drug beyond where that dose was further lowering the blood pressure. So despite having no further effect on blood pressure, high doses were more effective at suppressing abnormal aortic growth. This was similar to what had been observed in people that had other conditions caused by excessive activity of a molecule called TGF-beta. That same molecule has been implicated in multiple features of Marfan syndrome. So on that basis, we and many others have pushed the dose of angiotensin receptor blockers such as losartan to the very high range of dosing, similar to what had been used in people with other TGF-beta related conditions like chronic kidney disease. In people with Marfan syndrome, we currently aim to reach a dose up to 2 milligrams per kilogram per day of losartan in children. In adolescents and adult-sized people, we would routinely use the full dosing of losartan of 100 milligrams per day, and sometimes would go even higher, up to about 200 milligrams per day. In some studies in people, like a study done in the United Kingdom using the medication irbesartan, very high dosing was used and was shown to be associated with slower growth of the aorta. Our current recommendation is to use a dose of around 8 milligrams per kilogram per day of irbesartan in children, and in adolescents and adult-sized people to use a dose of 300 milligrams per kilo per day, and in some circumstances we would go as high as 600 milligrams per day. These recommendations are just broad general guidelines, but the specifics require careful conversation with your doctors, requires close monitoring and assessment of tolerance. Unfortunately, we've seen that even at very high dosing, both children and adults typically tolerate these high doses of angiotensin receptor blockers. So it's quite rare that we would be limited by any side effect.
Okay, great. Somebody was asking, how important is it that the exact dosage of losartan is taken each day?
So losartan is a type of medication that blocks what we call a receptor that sits on the surface of cells. Beta blockers, as their name implies, also block a receptor that sits at the cell surface. Whenever you block, or in general, when you block a receptor on the cell surface, the cell's response is to make more receptors. But that's okay because the medication blocks them all. If you suddenly take the medication away, you have more than the normal number of receptors being stimulated, which can cause problems. It can cause excessive stimulation of cells. And in animal models, when we did that, we saw that aortic growth accelerated rapidly when we suddenly stopped medications like losartan or irbesartan or beta blockers. So the general guideline is to really be very conscientious about taking your medication every day. If you occasionally miss a dose, it's not going to make a big difference. If at the time of a surgical procedure, your doctors choose to stop the medication for a day or two, it's not going to make a big difference. But if you have the habit of taking your medication for 3 weeks, stopping it for a month, taking it for 4 more weeks, stopping it for 3 weeks, that's the kind of pattern that would really be worrisome. The right answer, try to take your medication every day. If you usually take the medication in the morning and you remember at night that you forgot to take your morning medication, you should still take your dose that evening. If you forgot to take your medication yesterday and you remember that, you should not double your medication the next day. You should just continue on the regular schedule of a daily dosing. So don't try to make up for a lost day, but you can take your medication later in the day if you remember that you forgot your morning dose.
Okay, thank you. Should you still be on losartan after having heart surgery and receiving a mechanical valve?
Yeah, so that's a good question. There actually has been a good study that addressed that issue. It was a study from the Netherlands, and they looked at the performance of people with Marfan syndrome who took losartan who had never had surgery, and they saw that on average, they had slower aortic root growth than people who were not taking losartan. They then looked at people with Marfan syndrome who already had aortic root surgery. It didn't matter if it was a valve sparing procedure or a mechanical valve, but they asked the question, does taking losartan after aortic root surgery help to protect the rest of the aorta? And the answer was yes, that in adults who had prior surgery, the use of losartan was associated with a lower risk of enlargement or tear or surgery for the rest of the aorta. More recently, that same group published a long-term follow-up study of up to 8 years of follow-up. And they found that same trend was maintained over time, that people taking an angiotensin receptor blocker continued to do well, and those that had surgery continued to show a better performance over time if they were taking losartan.
Okay, thank you. Is there a benefit to being on losartan over irbesartan? Should they be taken together? Have they been studied together?
Yeah, it would make no sense to take both of the medications. They're both in the same class of medication called angiotensin receptor blockers. They both block the identical receptor. They're both good at their job. They're both efficient medications to block that receptor. Losartan was the very first angiotensin receptor blocker that was released. Because of that, the doses that were tested in people were on the modest side. There is some perhaps advantage to using newer generation angiotensin receptor blockers such as irbesartan because there's a little bit more of an aggressive dosing schedule, a little bit more leeway. The irbesartan is a little bit longer acting than losartan, but I have really no problem with someone taking either of those two medications. And in fact, I also don't have a problem with someone taking other medications in that same class. There's a medication called candesartan and another one called valsartan. There's a wide variety of angiotensin receptor blockers. And we've cared for patients that were receiving many of those medications, and they all seem to be doing pretty much equivalently.
Is telmisartan one of those that are similar?
Yes, again, would be in the same family.
Okay, great. Can you take losartan if you have mitral valve prolapse, or can that be detrimental to the progression of the mitral valve regurgitation?
Yeah, so there's no evidence that taking a medication such as losartan would be detrimental to the performance of the mitral valve. If someone does have a lot of leakage through the mitral valve, a medication that reduces blood pressure is sometimes used to decrease the amount of backward flow through the valve. Medications like losartan or like ACE inhibitors or others are commonly used in that circumstance. So the answer is there's no contraindication to use an angiotensin receptor blocker in someone with mitral valve prolapse. But again, all of this needs to be individualized, and all of this needs to be discussed with your own doctor.
Right. And when is losartan or another drug appropriate for a newly diagnosed child, let's say 2 years old? How young would you prescribe it?
Yeah, so we and many others routinely start a medication such as losartan at the time of diagnosis with a vascular connective tissue disorder, including Marfan syndrome or Loeys-Dietz syndrome, for example. That includes very young children. We feel confident based upon the literature and based upon a lot of experience, even before medications like losartan were considered for use in Marfan syndrome. There was lots of experience using drugs like losartan in young children for a wide variety of conditions. There is some incentive to get past the immediate newborn period. So it would not be something that we would routinely do in someone less than 3 months of age. In the clinical trial of losartan that was done by the Pediatric Heart Network, we recruited people with Marfan syndrome that were 6 months of age or over and did not see any detrimental consequence. So I think the answer that I would give and the answer that I use for my patients is that we use the medications at the time of diagnosis. I think it would be especially important to use the medication if there is a strong family history of aortic disease or aortic enlargement in the young child that has shown itself already. I would have no reluctance to start losartan in infancy, beyond 3 to 6 months of age.
Okay, thank you. Do the treatments such as losartan that help with aortic aneurysm also have positive outcomes with regards to problems with other vascular problems, like outside of the aorta, whether it's with Marfan or Loeys-Dietz, another condition?
Yeah. So as I mentioned, there was good data from people with Marfan syndrome that use of drugs like losartan could protect the rest of the aorta even after aortic root surgery was performed. So we would anticipate that would also relate to other places where aneurysms can form. In Loeys Dietz syndrome animal models and in Marfan animal models, the use of angiotensin receptor blockers like losartan not only slow the rate of growth of the aortic root, but they also greatly extend the life expectancy of the animal. So we're not seeing, for example, them having tears and ruptures of other blood vessels in other parts of the body. On that basis, we believe that the medication is providing protection to other sites along the arterial tree. There is evidence in animal models that angiotensin receptor blockers can protect other tissues besides the vasculature in Marfan syndrome. For example, we have seen beneficial effects in the mitral valve. We've seen beneficial effects in the skeletal muscle and in the lung. So that has not been studied extensively in people with Marfan syndrome. So I'd have to pose that as a possibility right now based upon the animal work rather than a conclusion.
Okay. Somebody with mast cell activation syndrome gave us a question. They can't take beta blockers because it makes epinephrine inert, and they're on calcium channel blocker instead of the beta blocker. But you were advising against the calcium channel blockers. So what other options would there be, or should they be on that?
So we're still learning about the potential detrimental effects of calcium channel blockers in vascular connective tissue disorders. Mm-hmm. It was very dramatic to observe the detrimental effect of calcium channel blockers on the aorta in mice with Marfan syndrome. After that experimental experience, we did use human data that had been collected by the GenTAC database, and we're able to demonstrate good evidence that people with Marfan syndrome that were taking calcium channel blockers were at increased risk for tear or surgery of the more distal aorta. So we still don't know the magnitude of that effect. We don't know if it applies to everyone with Marfan syndrome. I guess our recommendation is that we prefer to avoid calcium channel blockers if there is a good alternative. For example, if someone has high blood pressure and there are other classes of medications that can be used, we feel that they should be used. If, however, someone has high blood pressure and the only thing that controls their blood pressure is a calcium channel blocker, we think that would take precedent, that person should take a calcium channel blocker, perhaps be monitored a bit more closely, but we would support the use of a calcium channel blocker in that context. I would need to know much more about this specific individual and what their underlying diagnosis is and what other classes of medications have been tried. But my general recommendation for people with vascular connective tissue disorders is to avoid calcium channel blockers if there's a good alternative.
Including people with VEDS, because that was another specific question.
Yes, I would, based upon what we've learned about the mechanism by which calcium channel blockers cause problems, I would also apply that to VEDS. I mean, importantly, there has been no good controlled large clinical trial of calcium channel blockers in any of these conditions. So there's essentially no evidence that they are protective in vascular connective tissue disorders. There's good evidence that they are able to lower blood pressure in someone that's hypertensive. So, in someone with a vascular connective tissue disorder who has a really high blood pressure, where no other medication has been shown to be tolerated or effective, then it might make sense to use a calcium channel blocker.
Okay, I'm going on to beta blockers a bit. Is there a benefit to being on propranolol over atenolol?
We don't believe so. We believe that atenolol is a good drug. There are other beta blockers that are used. Another common one is metoprolol. They're relatively long-acting medications, so they're convenient to use. I don't have a strong preference with regard to which beta blocker is used for folks with Marfan syndrome.
Can you talk a little bit about children taking a combination of beta blocker and losartan, and what's your recommendation on that?
Yeah, it's a good question. So the recent meta-analysis that was reported by the Oxford group, I think has provided a lot of clarity to the field. So what a meta-analysis is an effort to increase the power of clinical trials by combining their data, by looking at all the people from many trials to try to reach stronger conclusions. Importantly, the Oxford meta-analysis was the ideal type of meta-analysis. They didn't just take the tables of data from different studies and sort of mathematically mush them together, but rather they reached out to the trialists for all these trials, and they were able to get the individual data for every study participant and then do a comprehensive analysis of all of those data. And the results were quite clear. They showed that people taking angiotensin receptor blockers had a significant reduction in the rate of aortic root growth. These are people with Marfan syndrome in particular. Essentially, in people who were taking an angiotensin receptor blocker, the rate of aortic root growth on average was cut in half. They showed that if the study participant had a definable FBN1 mutation, there was clear evidence that the actual diagnosis was indeed Marfan syndrome, then the magnitude of effect was even greater. There was a greater reduction in the rate of aortic growth, even beyond having it. They were also able to show that people who took beta blockers had a similar performance to people who were taking angiotensin receptor blockers, but that the effectiveness of an angiotensin receptor blocker did not correlate with a reduction in blood pressure and did not require use of a beta blocker. So by a somewhat indirect but valid analysis, it led to the proposal that the combination of an angiotensin receptor blocker and a beta blocker had the potential to provide greater protection than either single agent alone. So either a beta blocker by itself or an angiotensin receptor blocker by itself. So Our general strategy in my clinic, and I fully respect that other people do this differently, but because of the direct evidence that angiotensin receptor blockers are protective, because in people, because of their superior performance in animal models when compared to beta blockers, because of their somewhat preferable tolerance profile, the lack of issues such as aggravating asthma or depression, our general strategy is to start with an angiotensin receptor blocker, to get that up to full dosing, so our target dose that we discussed before, then to reassess the situation, and if there's ongoing room for improvement based upon the pattern of growth of the aorta, to then add a beta blocker. I feel very strongly that people should have one or the other drug fully optimized at full desired dosing before adding a second class of drugs. So I don't have any reason for confidence that a little bit of this and a little bit of that will be okay. I think you should be on one drug at full dosing and then add the other. I know that some people would use a beta blocker first and then consider adding an angiotensin receptor blocker. And although that's not my preference for the reasons I mentioned, I would fully respect that practice as well.
So here's somebody who I think is looking at the next step. This person said that her daughter has been on irbesartan and propranolol, and it's stabilized her aortic root growth. They're grateful for it, but they want to know if there's something they can add that might help to shrink the aortic root back to a normal size. So that seems like the next step on top of what you just described.
So we have seen the size of the aorta normalize, but importantly, that's I've only observed that in growing children. The aorta, in my experience with any medical therapy, never will truly get smaller, but it can become normal when compared to body size as a child grows. So my goal in using medications is to stabilize aortic size while allowing the body to continue to get bigger. The way that we monitor an aorta in a growing child is to calculate something called a Z-score, which means how far from average is the aortic measurement when standardized to that child's age and that child's size. Our hope is to see the Z-score declining in someone who's growing. That means their body's getting bigger, their aorta is not. It's not okay, it's not sufficient in my mind to, in a growing child, to just see a stable Z-score. That means that the aorta is continuing to get bigger as the body gets bigger. I would say that there's still room for improvement in that circumstance. In someone that's finished growing and is not gaining weight rapidly, a stable Z-score is what we'd hope for. That's the best we can hope for, because the aorta will not decrease in size over time and the body is not continuing to get bigger. So it would depend on the age of your child, the pattern of growth of your child, whether growth is complete. But as of this moment, I think from a medical standpoint, you're currently using what we know to use. That doesn't mean there won't be developments over the next few years. So I would stay tuned for that. There are other things that can be done to optimize the performance of the aorta. That includes getting the right kind of exercise, moving activities done in moderation that will naturally lower heart rate, lower blood pressure, and work in your favor. That includes avoiding some types of physical activities like exercise to exhaustion or really heavy muscle straining kinds of activities. But it sounds like your child is in a great place. So congratulations. And it sounds like you're doing everything correctly.
Great. Can you comment on the results of the Oxford doxycycline trial for Marfan syndrome?
Yeah, so I don't know that final results have been published. If they have, I haven't seen them. So I'm aware that a study of doxycycline was planned. I was aware that there was some activity along that line, but I have not seen any final report of results.
Okay. So now on to oxytocin. So should oxytocin inhibitors be used postpartum in all new Marfan moms?
So, we're not even close to making that kind of blanket recommendation. Oxytocin is a natural hormone that's released at high levels by women to initiate delivery of a baby and to also allow breastfeeding to occur. Oxytocin is present in women who are not pregnant. It's also pregnant at lower levels in men. Now, in women with vascular connective tissue disorders, there has been an observation that many of the vascular events occur either very, very late in the pregnancy, around the time of delivery, or even deep into the postpartum period, especially in women who were breastfeeding. In mouse models, we were able to show that oxytocin is stimulating aortic events in the postpartum period after delivery. That was true in mouse models of Marfan syndrome. We have the same evidence in mouse models of vascular Ehlers-Danlos syndrome. If you allowed the mice to become pregnant, allowed them to deliver, but then took the pups away right after birth to prevent lactation, to prevent essentially mouse breastfeeding that would stimulate oxytocin, we were able to achieve dramatic protection from vascular events. Does that now lead us to the conclusion that no woman with Marfan syndrome should breastfeed and every woman with Marfan syndrome should receive an oxytocin receptor blocker? No, we're very far from that point. There are researchers in the field, including a good friend and colleague, Melissa Russo, who are studying this by seeing if women who chose not to breastfeed, who had a vascular connective tissue disorder, did better than women who did choose to breastfeed. My role, I think, right now is to make people that I care for aware of these results, make them aware of choices that they have regarding practices such as breastfeeding, make them aware of what we still don't know, and then support them in whatever decision they make. In certain circumstances, I think that a decision, for example, not to breastfeed might be justified. In a family, for example, where someone with Marfan syndrome had an affected mother who died a week after she was born, and affected aunt who died a week after her cousin was born, and another aunt who experienced a pregnancy-associated dissection in the postpartum period in association with lactation. I would not tell that woman not to breastfeed, but I think I would tell them that if my daughter were in that circumstance, I might encourage her to avoid breastfeeding.
Great, thank you. So now a little bit on beds and medications. So you showed in your talk that in your mouse models, celiprolol did not show a decrease in major vascular events in beds. How does this compare with other studies? And can you comment on that further? Other studies of celiprolol?
Yeah. So the only other studies with celiprolol that I'm aware of were some human studies that were suggested that people with vascular EDS who took celiprolol had a reduced risk of vascular events. The original clinical trial that was aimed at answering that question was relatively small. It had some issues with regard to documentation that people actually had vascular EDS, including many study participants who did not have a mutation in the gene that we know causes vascular EDS. So there were some suggestive data. There was a follow-up study. It was not a trial, but just an observational study that suggested that people with vascular EDS that were taking celiprolol seemed to have a somewhat reduced risk of vascular events. But the important fact in my mind is that the regulatory authorities, the FDA, for example, in the United States, looked at these data and said, these data are not sufficient. They're not convincing to us regarding the efficacy of celiprolol in protecting people with vascular EDS. A larger, better controlled, longer study needs to be performed. So the FDA declined to approve the use of celiprolol for vascular EDS on that basis. To my knowledge, European regulators have not approved the use of celiprolol for vascular EDS, but celiprolol is used for other reasons in Europe, so physicians can prescribe it. But there is no, to my knowledge, there has been no validation by regulators that there's sufficient evidence of protection with celiprolol. So I think the right answer is that it's an open question. In our mouse model of, in fact, 2 mouse models of vascular EDS, celiprolol afforded no protection from vascular events. That was true in a mild model and also in a severe model. And in fact, in our experience, the mice treated with celiprolol seem to do somewhat worse. But I've reached no conclusion on the value of celiprolol in vascular EDS. The only answer is that I think that it needs to be rigorously studied. There is a clinical trial of celiprolol that, to my knowledge, is ongoing for people with vascular EDS. I do not know the current status of that trial, but my advice to anyone that is considering the use of celiprolol for vascular EDS is that it should be done in the context of a study, and they should be closely monitored.
So somebody is asking if there are family members with beds who are on celiprolol, should they continue, or would you suggest they discontinue?
That's a very personal decision, and I suggest that they have a discussion with their doctors. I suggest that they get all the information that they can regarding the level of evidence for its use, and then I suggest that they reach a personal decision with regard to risks and benefits of use of the medication. So that's a very personal decision, and I've had that exact conversation with many people, and I support the decision that they arrive at after I provide all the information that I think they need to make a good decision.
Okay. Have either, and I'm sure I'm going to botch the names of these, but have either spironolactone or eplerenone been explored in humans with beds, or is the study in mouse models? You showed the first of it.
Yeah, so we have studied spironolactone in mouse models of beds, and there was a significant protective effect in both male and female mice. Spironolactone is an approved medication. It's a class of medication called a diuretic that causes increased urination to eliminate fluid from the body. Spironolactone also has another activity in that it blocks the effect of male sex hormones by binding to and blocking the androgen receptor in the body. So its use in males is somewhat complicated by that. It can cause breast development in men, so-called gynecomastia. That can be mild. It's fully reversible if you stop the medication. It can cause suppression of the development of other males' secondary sexual characteristics, for example, facial hair development. So it's not something that's easily used for everyone with vascular EDS, and just like I mentioned about celiprolol, I think that it is best used in the context of a study. I would again advise that anyone with vascular EDS that's using spironolactone should be monitored carefully. The results with eplerenone, which is a molecule that blocks a receptor in the body called the mineralocorticoid receptor, those data that I shared were brand new. So we just have made those observations in mouse models. We're doing more work to better understand the mechanism. Again, not ready for routine use in people with vascular connective tissue disorders. Although, again, FDA approved and currently used to treat some people with hypertension.
So what medications should VEDS patients discuss with their cardiologists based on your findings? Anything new that people can take from what you presented?
So again, I think that that's a very personal decision. It should be based upon the specific circumstances of a given individual with VEDS, whether, for example, whether or not they have hypertension. Our data suggested that medications like angiotensin receptor blockers did not significantly improve or aggravate disease in our vascular EDS mouse models. But data from a group in France with a different bona fide mouse model of vascular EDS demonstrated that losartan showed significant protection in vascular EDS. So, I think that is something to consider. At a minimum, it will help to keep blood pressure low. So I think that's a possibility. I think traditional beta blockers can be considered. If nothing else, they naturally lower heart rate, lower blood pressure, and could afford benefit in vascular EDS. Again, in mouse models with traditional beta blockers, not celiprolol, but beta blockers such as propranolol or atenolol, we didn't see that they afforded significant protection, but again, didn't aggravate the situation at all. So I think that is something that can be considered. I think in selected circumstances, carefully considered circumstances, that some people might consider use of spironolactone. There are some reasons that some of my patients with vascular EDS were on spironolactone before they even knew they had vascular EDS. For example, women with hair loss or people with some severe forms of acne. I have a handful of people who are taking spironolactone. It's not something, again, that I'm pushing, and we are monitoring those people very carefully. I think right now the field is in a little bit of flux about what's best. I think that there are some reasonable options, and I hope that there will be more information soon that would allow more definitive choices to be made.
Great. Thank you so much for taking all your time answering these questions. We look forward to seeing what comes next. And I know that whatever you're going to be presenting next, people will be ready to listen and anxious to hear what you learn. So thank you so much.
Well, I look forward to another set of great questions. So thank you all for being interested and for participating in research. I mean, it's such a vital contribution that you are making to your hopefully yourselves, your families, and to others with vascular connective tissue disorders. So thank you.